Thanks for having us. Not all of us are from Pointe-Claire, but a number of us have deep Pointe-Claire experience. So we're going to try to step back from that role and take a look at a bigger role in healthcare, and specifically talk about how senior living plays a really, really critical role in the future of the experience of healthcare and really the economics of healthcare moving forward. So if I'll just give you kind of a quick preview of what we're going to talk about. I'm going to try to get out of the way and let the experts talk, but we'll take a quick overview of Triple Aim. I can't see too much because the bright light's shining, but if you could raise your hand if you're familiar with the Triple Aim, just to kind of get a feel. So a few folks out there. Looks like it might not be sort of comfortable for everyone. Don't worry, we'll not assume that everyone knows. We'll take a quick overview. We'll connect the Triple Aim to senior living. Triple Aim, I would say, is really targeting the people who live in your communities, and it's really meaningful when you unpack the Triple Aim. So we'll do a little bit of connecting dots there, and then we'll talk a little bit about the continuum of the Triple Aim and how to get involved and engaged in some steps that you can take that are practical in kind of moving forward and engaging in unlocking this promise for the people that you serve. Let me introduce the panel so it's not super awkward while I go through a little bit of setup. We have Mary Mercier, who's industry market leader for senior living and senior care. I've spent the last 7 years at Pointe-Claire. Mary, you and I have known each other that entire time. Mary is a passionate advocate for senior living in particular, and has really done a lot to help Pointe-Claire really unlock the potential and make some investment that's meaningful in this area beyond the skilled nursing roots that Pointe-Claire started with. Next, we have Craig Erickson. Craig, I met probably, 6 weeks ago via phone. Craig's executive director of Erickson Senior Living. I just love the story. I loved getting to know you on the phone, and I love what Erickson is doing and stands for, and has been really innovative. So we'll ask some questions about Craig's experience and sort of becoming a player sort of in healthcare. I guess you could say that. Is it safe to say? And then Steve Buzlovich. Steve and I have known each other, like 5 years now? And Steve's company called Patient Pattern was just acquired by Pointe-Claire. Steve's vision is incredible for patients as people. He's been a big advocate of frailty, which is a holistic view of people as sort of they navigate through the later periods of life. And there's some significant implications for how we think about helping not only people but caregivers navigate aging and particularly end of life. So, and Steve's an expert in value-based care models, and we'll be spending some time kind of talking through some of the value-based care implications for senior living and where there's a lot of crossover that's either here or coming. Okay, before we get into the Triple Aim, this is something we rally around at Pointe-Claire. I lead our product team for senior care, and we talk about this just about every day. Our mission is not to sell more software, to build software, but it's really to preserve the health and independence of seniors. We are a partner in that mission with our customers, with you, and we don't have all the answers. Technology is not the answer to everything. We have to find ways to leverage technology, as we just heard, to really unlock some of the promise. So when we think about technology, one of the things that is a quote that I like to go back to a lot, and we'll get to the Triple Aim, I promise, but there's a guy named Melvin Conway who was focused on technology, and actually this quote is about information systems or big technology systems, but it's really a little bit more poignant and kind of speaks to healthcare. And really what this is saying is any system, including healthcare, is as good as the social structure that delivers it. And one of the reasons that both the social structure, or that healthcare is so difficult to navigate, is both the social structure and the technology structure is very, very siloed, as we all know. But that's just a reflection of the many hands that are in the pot. And so I think more and more we need to think about how to tear walls down, how to partner. Pointe-Claire won't build everything. We will partner extensively. We will build more and more with the purpose of partnering to unlock some of those technologies, to make information flow freely. it's really, we want to be a broker of information, not an aggregator or a hoarder of information. So what is the Triple Aim? I promised I'd get to this. Triple Aim, if you're not familiar with it, is focused on improving the health of populations. It's really honestly focused on improving the health of high needs populations, most pertinently. The reason for that, or one of the reasons for that, kind of no big secret, is improving health reduces costs. So reducing per capita cost of healthcare, particularly for high needs or high utilization populations, is really critical. But the Triple Aim, to its credit, did not lose sight of the fact that people are patients, and improving the healthcare experience for people and those that care for them is really critical. Now, there's quadruple aim and quintuple aim, and people are adding and adding to the aim, but we'll just keep it with the triple aim for today, and we'll walk through talking about triple aim. So I'm going to shift gears now and talk about the triple aim and really hopefully connect some dots for triple aim and senior living. When you think about the triple aim and focus on populations, your communities, the communities in which you provide care, are populations. They are populations of high density of those who have high needs for support. And so the people you serve are some of the most important populations to serve in our healthcare system. And quite honestly, I feel like you've been asked, maybe not formally, but to cover a lot of the gaps in the healthcare system, to really be the glue that holds the healthcare system together for those populations. And we need to find a way to make that easier to do and to make that better. So starting with the people, the communities, the people you serve, our populations, and the triple aim, I think, speaks very specifically to populations like those that you serve. Secondly, you are great at experience as a differentiator, and it's key to your businesses. So you do a lot, and I've seen a lot of this, and I've learned a lot about how you differentiate yourselves by the experiences that you deliver in your communities. The Triple Aim, again, I'm grateful, did not forget about experience of people in healthcare as a really important theme. And I think you, as experts in experience, really have a lot to offer from a Triple Aim perspective. And the third, and this is, bear with me a little bit, but when you think about the healthcare continuum, if you move from sort of left to right with hospital all the way to community, as you move from left to right, the per capita cost of care goes down. So the longer we can keep people living in communities, in lower acuity settings, living at home, where your communities are home for the residents that you serve, the longer we can have people living in community, the lower per capita cost there will be. And it's not just about lower per capita cost, the experience is also better. And there's great data on this that I won't go into today. But when length of stay increases for your communities, we are achieving the triple aim for healthcare. And I think it's important to make that connection. So the first thing is just let's acknowledge and be aware. So we're going to shift gears and talk about sort of some things that we can do, and I'll get to the panel in just a minute. But the first part of this is just acknowledging and being aware that you've been asked to be the glue, and we haven't given you great tools: phone, fax, paper, business cards with sticky notes, organized by category. These are things that are real. But there are better ways to do this. There are better tools. There's access to information that we'll talk about in a couple minutes. So this is not good enough. And I think just acknowledging from a mindset perspective that, one, you're doing this, you're providing this important role, making sure your staff acknowledge that, but also really looking together with many people to find better tools to do this is really important. Not just point-click-care, but there are many technologies out there that will make this easier and better. At our point-click-care summit, and I don't mean to sound like a point-click-care infomercial, but this year at Summit we did something a bit different. On main stage, we actually went through the journey of a fictitious patient named Ramesh Patel. What you can see from Ramesh here is that it's not simple. Ramesh is older. He's multi-comorbid. He's had some issues. And as we followed him through his journey, what became clear, I think, from the story and what's clear from what you deal with every day is that healthcare is difficult to manage. It's really complex. And at every transitional phase, it feels like starting over, and it's really hard. And so when we think about a journey of moving into a different environment, or starting a different episode of care like home health, or transitioning to hospice care, or going to a hospital and then coming back via a stay in a SNF, all of those handoffs and transitions are important. Not all transitions are accompanied by changes in location. And it's really important to make information flow, whatever type of transition we're talking about. So as we think about transitions and data flow, it's important to think that there's a macro trend in healthcare that is really compelling all of us to get better at not only transitions, but also sharing of information, and not just making those transitions easier. So the first question is, where is someone? What are the services they're receiving? How can we make information available to them? The question we all really want to answer, and this is really where we unlock value from a value-based care perspective, is this the right set of care and services for this person right now? And is this the right setting for them to be in? And if you think about this slide from sort of left to right, there's a lot of Medicare-driven programs that are driving value-based care. CMS's espoused goal is 100% value-based care by 2030. What we can see is that accompanying that is, and the reason for a lot of that is to control costs, because the high acuity population is growing. I'm sure you feel that every day. And care is increasingly delivered in community. And it's really difficult to deliver high acuity care in the broader community, although there will be some of that. But when we say care at home, your communities are home. And I think your communities are one of the most important models of home, given the aggregation of populations of high need and the level of engagement that you have with that population. So if you think about population health, it's not just about moving information and having cohorts and saying this person needs a diabetic eye exam. It's really about thinking about how do we actually actively manage the whole person and engage people in community. So Steve will talk a little bit more about this, but make no mistake, healthcare is in a significant transition from volume-based care to value-based care. As an EHR, we are transitioning really from how do we support fee-for-service models to how do we support holistic health and delivering value. So things are becoming much more important in terms of social determinants, the holistic person, not just a transactional, physician office or a hospital stay from an EHR perspective. Value-based care models require a number of things. And so if you think about it, multidisciplinary teams are critical. You saw some allusion to technology and remote monitoring a little bit earlier. Virtual access to resources. The pandemic had a bit of a silver lining in that it really pushed a lot of virtual interactions and technology to support that. That's not going away. It will just increase. I think, as we think about AI and other things, not only figuring out what happened or what's happening and why did it happen or why is it happening, but doing predictive analysis and saying what will happen, what could happen, how should we intervene to make a better outcome. And ultimately, a lot of that is targeted toward the home. And when we say home, it's not just a home in the broader community. Home that is really important is in the communities that you work and deliver services in. So as I mentioned, PointClickCare has recently acquired Patient Pattern. I won't spend a lot of time on that, but Patient Pattern is really one of the most innovative companies that we saw as PointClickCare in looking at the whole person, understanding not just risk for rehospitalization or risk for a bad outcome, but understanding frailty, really all of the aspects that go into threatening health and independence, and then orchestrating care and plans of care around that with a physician-driven medical model where physicians or nurse practitioners are highly engaged. And we're really excited. The Patient Pattern Care Coach Toolkit is being employed probably most prolifically right now in institutional special needs plans in skilled nursing facilities, but we're really excited to expand its use. It's already serving broader community programs like PACE and ACO REACH and others. However, we're really excited as a company to expand that as part of our significant investment in senior living and broader community care. So I did quickly want to get to that. My notes are not here, so I'm going to have to go by memory on the questions. But I'd like to start with Murray and just ask you a question, Murray, about the slide that we showed that was phone and fax and sort of paper records.
Sure.
Can you talk a little bit about your experience actually doing that in the community? Because that's where your roots are, and then talk about how you see the technology really changing the way that's done and some of the critical things for people to think about.
Sure. And I might first start off by saying that it took 20 years, but Craig's beard game has finally surpassed mine. And it perfect timing since we got to be on stage here, so I'm a bit embarrassed by that. Yeah, I have the privilege of getting to work with many of you and seeing the communities. That's where I'm happiest engaging and being around. I generally see three different styles of engagement with the healthcare ecosystem with value-based care, care coordination. But make no mistake, we're all care coordination agents for our residents. They're in fact demanding that. That came up as one of the top industry trends for 2023 is that prospective residents are demanding that we help coordinate their healthcare. It's not that they have one doctor and they just are going to do it themselves, right? They're seeing 30 different specialists and they don't want to deal with it anymore. They want us to offer those services. So generally what I see is either organizations that are not strategically addressing this issue and they're just letting their local community care agents play that role. So it's basically up to how much does the person in the community actually care about the resident they're caring for as to how engaged they'll be with the healthcare coordination of that individual. The second thing I see is a more strategical organizational approach to it that we know we're care coordination agents, so we're going to deploy technology and deploy process that assist those people in the community in keeping track of all that care coordination. It is a lot of work. I remember sitting in the office as a resident care director helping to facilitate what's the maximum VA benefit for the individual sitting in front of me. And it wasn't easy. I spent a lot of time on hold. It's getting easier, right? But identifying that, hey, we do this and giving the employees at the community both technology and time in their job responsibilities to actually play that role. And then the third one, and there's several groups in here, I know Juniper is more engaged as actually becoming a payer provider to the different opportunities that are out there. Erickson plays at the game. Ohio Living, I know, played in Medicare Advantage in the last year, and saying that, hey, this is an investment, even if it is a negative investment at this point, but it's impacting my length of stay, and I'm getting this upside in other areas of my business. So that's generally what I'm saying. To your second question about what you can do today, there's this idea in technology, that we need to take responsibility for our data. We're not just turning technology on, and you shouldn't just turn technology on approach to, like, just don't get a device and turn it on and hand it. Like, really think about how informatics plays a role in this care coordination agency, because it's really important. So I'm going to get out of the way because
No, that's great. I just want to piggyback on the technology thing. I mentioned this earlier, but Point-Click Care doesn't necessarily have it all figured out, and I'm glad that we're in an innovation forum because here is where we come to essentially offer to partner and continue to offer to partner with folks like you. If you've looked at Point-Click Care over the last couple of years, there have been some big investments in acquisitions that are focused on access to data from the network, primary care data, pharmacy data, other data. We have something called Point-Click Care Connect, which is really an interface to all that data, but how do we use that effectively and how do we envision the future in a way that's in partnership with you versus us just thinking about that? I think it's something I'm really excited about. I know Murray's really excited about it. You can talk to us offline about that. But I think there's a lot of potential for technology to make things so much easier just to see what's going on, to have contact information at your fingertips, to have some work cues for reminders to do things. There's just a lot that we can do, and we're excited, I think, to think about how to do that together. Any other final
Well,
comments?
yeah, and you made me think, like, we want to move our data to information. Just collecting pieces of data is not going to do anything. We need to move that to information, and we do that through informatics strategies. So if you're not in your businesses at the top level talking about what informatics strategies are and how data comes together to create information that drives the focus of your business, you need to start yesterday.
Cool. So speaking of starting yesterday or maybe 10 years ago or something, Craig, when we first met, you were telling me a little bit of the story of how you were motivated to start your own MA plan and how you have primary care engaged in your communities. Maybe you can just talk a little bit about that story, what motivated you, and how you've used primary care and other things to help coordinate healthcare for your communities.
Yeah, definitely. And I would say not me. It was actually my father, John Erickson, who started Erickson Senior Living and came up with the idea of creating a health plan. But we build these really large CCRC life plan communities that are very comprehensive in terms of the care. And I think he realized the day a senior moves into one of these communities, or really any of our communities, they suddenly become much more profitable to their insurance plan. Right? They're not shoveling snow, they're not climbing on ladders, they're walking long distances to get to the restaurants, they're having socialization, so they're not dealing with the adverse health consequences of loneliness, good nutrition through the dining program and meal plan. And so, I think his motivation was we deserve to capture some of the value that we're inherently creating. And so that's where we have a Medicare Advantage plan. So I'm the executive director of the best of our 20 plus communities out in Colorado. And I've got 500 of our 2,000 residents who are part of our Medicare Advantage plan. And we have a physician practice on site, 3 doctors, 2 PAs. In the Advantage plan, we have a member services person who can handle the complicated billing questions that come up. He sits on the phone, with United Healthcare. And then we have an RN who's a care coordinator. And so she'll work with the more clinically complex members in that plan to really make sure that we're optimizing their use. Give one quick example. It can kind of go both ways. We have a resident female who, recovering from a leg injury, wants to get back to her apartment with her husband. We know that he can help her with transfers, wheel her down to outpatient therapy. Why not let her get back to where she wants to be at a lower cost setting where she's going to be happier, can engage in bridge with her friends and stuff like that. Had another resident who was ready to be discharged from skilled nursing, and one of the staff members said something's different with her. It didn't need to require a hospitalization, but the care coordinator came on, down to the building, took a look, and said, yeah, her stay needs to be extended. And so, you can make decisions like that that really optimize the experience for the residents.
How has that over time, sort of the level of enrollment and the utilization of primary care changed? I think you mentioned it's kind of grown. What are some of the obstacles, to continuing to grow, to have more people in your community, in your plan, and more taking advantage of that primary care model?
Yeah, I think one reason people don't pick it is because they've got a retiree plan that has great, benefits, and we can't compete financially. Medicare has some restrictions where we have to submit all the benefits. We offer transportation to specialists, and they kind of tell you, no, you can't charge less than this amount, and so that's the challenge. And then we see some residents are just oddly loyal to this insurance company that they've been with 20 years because they took care of my husband when he had cancer, and so. But we really do try to get in front of them and help them understand how they can benefit from being in a plan like this.
Do you feel like the stories that you mentioned of individuals in your community, like the woman you mentioned, does that help resonate with others who might change some hearts and minds? Like, do people tell each other about that and sort of recruit a little, or?
Yeah, the storytelling absolutely helps, and having some residents who are willing to talk about their experiences. Gosh, I got this bill and I just walked down and handed it to George, and the next day he called back and had everything straightened out. All those experiences really help, and we feature our residents and helping convince other residents to sign up as well.
Awesome. So I'm going to switch gears just a little bit and go to Steve. Steve, we hear value-based care anytime there's a healthcare conversation now. I use the terminology somewhat loosely as well. Can you just talk maybe about a couple of the value-based care models that you think are most pertinent to senior living communities and how you see the landscape changing and sort of growing and expanding?
Sure, thank you, and really nice to be here. I just want to take a quick survey to see how many folks in the audience are participating in some sort of value-based care arrangement, whether it's a passive or an active model. Can you raise your hands if you're involved in something? So just a few, and that's actually great. You know, my interest in value-based care really stemmed as a medical director of senior living organizations and skilled nursing facilities. I was taking a risk in an institutional special needs plan, needed a way to actually extract data on my patients from the buildings, connected with what the health plan needs, and be able to service both fee-for-service and value-based care patients in a similar setting. And so, you know, these models have grown because as you drive better outcomes, these are new revenue opportunities for provider groups that are essentially looking at you know, expanding their services, expanding their revenue opportunities, and Medicare has forced the penetration of value-based care arrangements in these institutional settings, in community settings, and it's only going to grow, and we've seen explosive growth in institutional special needs plans. So for those that are unaware of what I'm referring to, Medicare has a number of different Medicare Advantage plans. These are fully capitated models. One of the most popular ones is a DSNP. It's a dually eligible special needs plan. That is more community focused. So these are individuals that are running around in communities. They could be living in AL, IL as well. There's an institutional special needs plan that's more focused on skilled nursing type of facilities. But what's interesting is the other subset is the institutional equivalent special needs plan, and that could be AL, IL, essentially as long as they have some fairly minimal criteria for functional dependence, they would qualify. And so what happens is now senior living organizations can participate in these value-based care arrangements, particularly on the upside. And so what's interesting is we service probably more than half of all the provider-driven institutional special needs plans in the country from a technology perspective, and they're growing like a weed, and they're looking at partners, provider partners, to grow in certain counties where they're licensed. But these provider groups really don't understand what the opportunity is. They don't understand what questions to ask, what services to sort of participate in, and how to take advantage of these new revenue models. But I can tell you, and without asking Craig here, I bet you the valuation of senior care organizations multiplies quite dramatically if you're taking a risk for a population in your buildings. And so being able to do that successfully is not easy. Number one is you need to understand your population, right? When you admit a resident to your senior care organization, what is the assessment like? It's usually fairly service-driven. It's not, you're not really looking at their holistic needs from a cognitive, functional, psychosocial domain. And then you're essentially managing them. And one of the challenges is ultimately tracking these patients over time. You need to understand how their trajectory is going, where you can integrate medical services, other specialty services, and be able to track this over a continuum. These patients will transition. The worst thing you can do is to have your patient end up in the hospital because there's a pretty good chance you take a frail patient that's hospitalized, they're not coming back, right? And so being able to bring in on-site services, know your population, know what kind of conditions you can and cannot manage, but ultimately finding partners in the community through primary care groups that are taking risk is the best advantage for senior care, because ultimately these either contracted or employed provider groups can come into your facilities and help your population remain in place, remain healthier, de-prescribe medications, right? Keep them out of higher cost settings. And that's really the triple aim, is tying all that together. But provider groups and operators really have never done this before traditionally. And so number one is often, unless you're pretty large, you don't have enough scale to become your own health plan. So you need to partner with somebody that does. And we work with a lot of these plans that are looking for these high needs populations in a captive sort of setting to basically create economies of scale, to bring in clinical services, to take on risk, to provide better benefits to that population. And so it's really a goldmine of an opportunity, but this is just the beginning of what we're seeing in senior living. And I think it's really exciting. There's no shortage of models out there. So I mentioned institutional special needs plans, institutional equivalent special needs plans. There's now ACO REACH. And I know some of you from having conversations yesterday are starting to engage and participate. We'd love to help you just have those conversations so you know what to ask for, what is the rev share potential, and essentially how to take advantage of these types of value-based care opportunities in your market. So hopefully
That's
provides
great.
a little-
I want to acknowledge that Steve said the P word a lot. The P word is patient. And I think I recognize and just want to recognize that we don't often like to use that word for people who are in senior living communities. I think I would submit to you the reason we don't like to use that word is because being a patient, particularly in our healthcare system in the US, has been a horrible experience generally, and experiences the way that you differentiate yourselves. But I think we need to start to acknowledge that the people in senior living communities are someone's patient. They have healthcare needs that are significant. You are already coordinating them. And let's change the game so that patient does not have a negative connotation that's associated with terrible experience. That's what I think we can do together using technology and using some of the push that's coming with value-based care and holistic models. I think that is a really, really critical thing. Someone is taking risk on the residents in your communities. I guarantee it. The question is, do you want to play a role in fostering care coordination for them and share in the benefit of that value that you're delivering? That is really, I think, a key question moving forward. And so part of this innovation forum is really coming together to push ourselves to think differently, to embrace kind of a different mindset. The name of this breakout was really, intended to be a little edgy. I personally believe, and one of the reasons I'm still passionate about working at Point Click Care is that what you all do and how we can work together is really critical to the quality of life and really to the economic situation in healthcare in the U.S. and North America. And it's really important, and I'm grateful to work on it with you. We have just a couple minutes left. We can probably take one or two audience questions, and then I just want to be cognizant of time to keep the program moving. But if there are any questions, maybe one or two, just to direct to a panel member, let us know. Don't be shy.
Brandon, I would just add that it's been interesting watching the shift around this to more preventative types of things, like covering fitness classes, covering balance assessments, really the heavy promotion on annual health visits. And that's another shift that instead of just allowing the residents to self-select, we really motivate them around that, because that preventative piece, if you can stop a hip fracture, just the amount of financial impact and quality of life impact, is huge. And so that's been a neat piece of watching it from an operational standpoint.
That's a great, and sorry I didn't open the door with a question for that, but that's a great point. When you think at a macro perspective, what CMS is doing as well, with an increased focus on home and community-based services and home and community-based services in AL and IL for an aging population, I think the broader government payer system is really recognizing the incredible value in not just making sure someone had a foot exam or an eye exam, but making sure we're thinking about prevention, we're thinking about social determinants, we're thinking about nutrition and all of those things.
I think that's a good point, Peter. I think the difference now is prior we were trying to do it in our own swim lanes, and now everybody's coming together. And so now the question is, are we ready? Do we have the partnerships and relationships in place? Because at the end of the day, it's the relationship. The tools will advance and get better and change, and the programs will advance and get better and change. But if you don't start with building that relationship up front and you're not working together across those streams, you're never going to ultimately get there, which is why value-based care is like going 2.0 right now, right? Try again.
I think the best catalyst to drive change is taking risk. And when different organizations with different alignments and incentives start participating in the shared risk model, they start thinking differently. All of a sudden, well, we don't need to see them every single day to generate revenue. Let's just see the most complex patient. Let's spend our time and resources on setting patient family expectations, because that is actually what drives all the poor outcomes and utilizations and lawsuits, et cetera. But there's no incentive in a fee-for-service mindset to do that, right? And so when everybody starts really realizing that there's a long-term opportunity here, things change. And I think that's what's exciting about value-based care is it's really allowing us to think differently and have those conversations, aligning all the different parties to basically play together. Whereas in the fee-for-service world, that's just there's no incentive, right?
And I would say two things, and we'll probably have to wrap here because I think we're out of time. But absolutely true that what's happening is a redefinition of primary care, both from a fee-for-service to value-based care, but also from a brick and mortar, you come to me, to a I bring services to you model. And so you've got a lot of different people coming in, Best Buy, CVS, everyone trying to think about some of them, and there's still tension around the old you come to me model. I think more and more the tension will push toward I bring services to you, and I do that in a value-based model, not a fee-for-service. Because when you come to me, it's very transactional. When I come to you, it's a service-oriented model. It can be much more holistic. A lot of natural tension, but I also think there's hope. And I think the hope comes from innovation. And I think this group is really key to that innovation. So thanks for the opportunity, and enjoy the conference.
And thank you guys, obviously, for taking the time to